Okay, so we will start. Good evening, everyone, and welcome our speaker and our audience. Today, we will have the webinar about cardiac diseases in COVID patients. It will be two lectures. First one will be introduced given by Dr. Sanjeev Kumar, and the second followed by another lecture by Dr. Juwairiya Al Ali. Then we will have 15 minutes question and answer. Shall we start, Dr. Sanjeev? Oh no, I need to introduce you first. I did not introduce you. So Dr. Sanjeev is a consultant cardiologist, interventional cardiologist in Rashid Hospital in Dubai. Also, Dr. Juwairiya Al Ali, a consultant cardiologist in Dubai and Rashid Hospital in Dubai. And then we will have a talk by Sanofi Industrial by Dr. Niaz. But we will start with Dr. Sanjeev and then Dr. Juwairiya and then question and answer. Please, for the audience, write down your question and then we will share it with the speakers. You shall start, Dr. Sanjeev.
Thank you, Dr. Abdullah. So my task today is to talk on COVID and heart, the reasons to worry. I hope I am audible to all of you nicely. Am I audible to you nicely?
Your sound is okay to me, doctor. You can go ahead.
Oh, great. In last 1 year and 9 months, after about 250 million cases and roughly 5 million deaths, we have learned a lot about COVID and cardiovascular diseases. Let me just fix my screen a little bit. Yeah, I think so. Just let me fix it. Okay. All right. We have learned a lot about the COVID and the cardiovascular diseases. We know now that the cardiovascular problems are second only to the pulmonary problems, and the cardiovascular system is involved in a number of the ways. The most common presentations of the COVID-19 illness and the cardiovascular system is presentation like acute coronary syndrome, like STEMI or the non-STEMI, typical acute myocardial injury without obstructive coronary artery disease, and it may present either as myocarditis or cytokine dysregulation or stress cardiomyopathy. Then COVID-19 illness may lead to the arrhythmias, heart failure, cardiogenic shock, pericardial effusion and tamponade, and a number of the thromboembolic complications in the cardiovascular system, like you see over here, the multiple large thrombi into the pulmonary arteries. So what I am going to do in my talk is to cover, mainly emphasize on acute coronary syndrome and acute myocardial injury without obstructive coronary artery disease. So first, talking about some data. So this is the data from the Swedish National Registry, which has been published in 2021 of large data, 86,742 patients. And the odds ratio of having acute myocardial infarction and the ischemic stroke, they vary from 3 to 6 in this study. So what is very important over here is in this large study, the odds ratio are 3 to 6, and they are not as high as they were reported in 2020. There is bidirectional interaction between the cardiovascular disease and the COVID-19. By bidirectional, what I mean that there are a number of the cardiovascular problems like hypertension, coronary artery disease, and diabetes mellitus, and these patients are susceptible to have the COVID-19 illness, and if they have the COVID-19 illness, they have a very severe COVID-19 illness. On the other hand, the COVID-19, it affects the cardiovascular system either possibly directly and most commonly through a systemic inflammation, which may lead to the acute cardiac injury causing the rise in the troponin, like acute coronary syndrome type picture, myocarditis, arrhythmias, and thromboembolism. So there are a number of the drugs which we use, and hydroxychloroquine and the lopinavir, ritonavir are not being used currently, but we do use azithromycin, and the remdesivir and the azithromycin may lead to the QT prolongation, and the remdesivir may cause the bradyarrhythmias like complete heart block in some of the patients. Initially, in part of the 2020, it was thought that the ACE inhibitors and the ARBs may cause severe COVID illness, but it is not true now, we know of. So what is the pathophysiology? In fact, the COVID-19 illness is a involvement of the vascular endothelium. The vascular endothelium here on the left side is the normal vascular endothelium with the intact basement membrane. It has a number of the pro-fibrinolytic anti-inflammatory substances, antioxidants like superoxide dismutase and the glutathione, etc. And this is an intact basement membrane. But what happens with the COVID-19 infection, that all these agents, they do get suppressed. The neutrophils, they are attracted to the basement membrane. They permeate over here, and these endothelial cells, they start dying. The basement membrane is exposed, and the basement membrane, vascular basement membrane, is highly thrombogenic, leading to the thrombus formation. And if the basement membrane integrity is compromised, it leads to the capillary leakage, leading to the adult respiratory distress syndrome into the lungs, thrombus formation into heart, stroke, the macrovascular and the microvascular thrombotic changes into the kidney, leading to the kidney problem and the vascular thrombosis. So in fact, the multi-organ system problem, what we see in the COVID-19 is mainly because of the endothelial illness. And what is very important is this is a pathological slide, electron microscopic. By electron microscopic, the SARS-CoV particles, they have been seen into the cardiac tissue, but they have never been demonstrated inside the cardiomyocytes. So what we know till now, that the viral particles, they do not affect the cardiomyocyte directly, and this is the infected macrophages which are there inside the myocardium over there. So still we do not know whether the SARS-CoV-1, it leads to the formation of the cardiac autoantibodies like in the Coxsackie-B infection previously or not. So a lot of the things are still evolving and are not very clear about the cardiovascular system and the SARS-CoV infection. However, when we talk about the myocarditis, then currently what is happening, that any case of the myocarditis or the myocarditis like picture we see in our clinical practice, we immediately start saying that it is because of the COVID myocarditis, because the COVID infection, as I said, 230 million people worldwide, very commonly, most of the people, they have been affected. But we should know that the myocarditis can be caused by a variety of the causes like autoimmune, toxic myocarditis, and a number of the infectious agents. If we talk about the viral etiology, a large number of the adenovirus, enterovirus, parvovirus, HIV, influenza, Coxsackie, they have been all causing the viral myocarditis. And so it is all the viral infections, they still exist over there, and the SARS-CoV-2 is only a small part of all the viral infections. So if you see a case with the myocarditis like picture, don't jump immediately to the conclusion that it is the COVID myocarditis. What is the clinical presentation? The clinical presentation is like the dyspnea. It may be the patients may be having the chest pain, may be having either tachyarrhythmia or sometimes the bradyarrhythmia also. Some of the cases they do have the fulminant myocarditis, and they may have the acute hemodynamic prolapse leading to the cardiogenic shock. What are the laboratory investigations required is the ECG, and what we see is the low QRS voltage, rarely the left ventricular hypertrophy. There may be some ST segment elevation mimicking the myocardial infarction. There may be the findings of the pericarditis also into the ECG. Cardiac biomarkers are elevated, so is the elevated CRP over there. What do we require is the blood gas, full blood count, liver function test, renal function test, the chest X-ray, echo study is very important, and then some of the imaging studies which will be dealt in the next talk in detail. The immunological test for the autoimmune diseases and the antibody titers for the various viral illnesses also need to be carried out if we want to reach to some conclusion over there. When we see the troponin elevation in COVID-19 illness, it's not always because of the myocardial infarction, it is just because of the myocardial injury. Because we know that the troponin elevation can be because of the severe hypoxia, sepsis, systemic inflammation, pulmonary thromboembolism, and the stress cardiomyopathy. And type 1 or the type 2 myocardial infarction, they constitute only a very small reasons to cause the troponin elevation. What happens after the COVID-19 illness? This is a very interesting paper in which they have done the cardiac magnetic resonance study and to detect the myocardial injury in the recovered patients of the COVID-19. The total number of the patients were 148, and in the CMR, they saw roughly in half of the patients, there was no major abnormality. About a quarter of the patients, they had the picture on CMR like myocarditis. Another quarter of the patients, they have the picture suggesting myocardial ischemia or the myocardial infarction, and 6% of the patients, they had the mixed picture. What is very important, what these authors have seen, that the myocarditis was limited only to 2 to 3 myocardial segments out of the 17 myocardial segments. So very small amount of the myocardium was involved, and the active myocarditis was seen hardly in 1/3 of these patients. So even when you use the sensitive technology like the cardiac magnetic resonance, you see the active myocarditis in very few patients after the recovery from the acute COVID illness. And what this group of the patients, they were in the age group of 65 and more. So if you see the myocardial infarction and the ischemia in quarter patients, it's not known whether they were having the pre-existing atherosclerotic coronary artery disease or the COVID-19 illness has caused in some of the way the myocardial infarction and ischemia after complete recovery. So how do the COVID cardiovascular involvement present? We presented last year this case on the possible association of the myocardial infarction and the COVID-19 illness, and subsequently this case was published into the French language also. So this is a 26 years man who presented to the accident and emergency of our hospital with 1 month history of gradually progressive dyspnea. There was no notable past medical history in this young patient, and he had only the mild COVID infection for which he was not hospitalized. He was not a smoker, not a hypertensive or non-diabetic. On admission, his heart rate was 117 beats per minute, and the blood pressure was normal. Oxygen sat was 98%, and he had bibasilar crepitations. So his ECG showed the Q waves in lead 1 AVL V5 V6 over here, and what you see, the decapitation of the R wave. So the voltage in the ECG is really very low. Decapitation of the R wave in V3 and V4. There are no appreciable R wave anywhere into the ECG. This is what is the common ECG presentation with the cardiovascular involvement in the COVID-19 patients. The chest X-ray showed cardiomegaly with some upper lobe pulmonary vein prominence. WBC count was elevated. There was no eosinophils, so the chances of having the eosinophil myocarditis were not there. The ALT was elevated, possibly because of the congested liver. The coagulation parameters were mildly elevated. And what was important in this young patient, the glycosylated hemoglobin was 6.7%, though he was not a non-diabetic. His cardiac troponin T was significantly elevated, 1,326, and this is the range for the myocardial infarction. It remained elevated continuously for about a week or 10 days in this patient. Cardiac proBNP was elevated, and so was the D-dimer in this patient. His platelet count, C-reactive protein, serum ferritin, and the renal functions, they were all within normal range. When we did the echocardiography, we found the severely dilated left ventricle and the left atrium. And what was very important, his interventricular septum, it was very echodense, like a fibrotic tissue. And there was a large thrombus which was hanging into the left ventricle. There was another thrombus over the left ventricular apex, and in the short axis view, we could see a small thrombus into the right ventricular apex also. So he was having a number of the thrombi into his right and the left ventricle. The ejection fraction was 15 to 20%. So his working diagnosis was acute heart failure, because he presented with the heart failure, and the hypercoagulable state because he had multiple thrombi into both the ventricles. And the differential diagnosis, etiological, was acute coronary syndrome, myocarditis, or dilated cardiomyopathy, myocardial infarction with normal non-obstructive coronary arteries, and pulmonary thromboembolism. So we did his coronary angiogram. He had normal coronary arteries. So the coronary arteries were not only normal, they were absolutely clean. So his acute coronary syndrome diagnosis was out from there. He did his CT pulmonary angiogram, and there was no evidence of the pulmonary thromboembolism. So patient had a very brief history of the symptoms and the markedly elevated troponin values, which went against the diagnosis of the dilated cardiomyopathy, because there was something acutely which was happened in this patient. His nasopharyngeal swab was negative at the admission and 72 hours later, but his IgG antibodies were positive. And I like to bring it to the notice that this antibody assay is having a specificity of almost 100% and a sensitivity of 94%. We did his hormonal profile, and his cortisol AM level was suppressed, and so was his ACTH level, though his thyroid functions were normal. And what we know that in the COVID-19 illness, following the COVID-19 illness, the hypothalamic pituitary thyroid axis as well as the hypothalamic pituitary adrenal axis are suppressed. So in this patient, his ACTH level were low, as well as his cortisol AM levels were also suppressed. Not only that, the virus, it acts on the ACE2 receptors into the beta cells of the pancreas, causing the destruction of the beta cells, and the new onset diabetes mellitus is also a well-known phenomena in these patients of the COVID-19. We did his cardiac magnetic resonance, and you see this is the vertical longitudinal axis image in which we see a large thrombus as we saw in the echo. We see another piece of the thrombus into the left ventricular apex, and the third thrombi which runs parallel to the into the anterior wall of the left ventricle. When we looked for the evidence of the myocarditis, there was only very subtle mid-myocardial enhancement showing the myocarditis-like picture. But what we saw was a transmural infarction pattern into the whole of the septum, as well as into the apical areas of the left ventricle over here. And you can see there was a thrombus in the left ventricular apex and the right ventricular apex. So it is a mid-ventricular level. Again, we see the transmural infarction pattern into the whole of the LAD as well as into the RCA territory over there. And in the apical area, it was almost circumferential over there. On the T2-weighted images, the myocardial edema was present only into a very small segment of the left ventricular apex, and there was a little bit of the pleural effusion on the right side. So overall, in this patient, the evidence of the myocarditis was very subtle, and the myocarditis cannot account for his severe LV dysfunction. And the pattern of the late gadolinium enhancement, myocardial fibrosis, and the severe thinning of the intraventricular septum pointed to the extensive infarction pattern of the LAD and the RCA territories. So we kept a diagnosis of the myocardial infarction with the non-obstructive coronary arteries. And this is the interesting, very interesting autopsy study which was published, and I ask all of you to go through this, in which they have shown that there is a possibility of the extensive coronary microvascular thrombi in the patients of the COVID-19 leading to the predominant infarction pattern, although this may not be uniformly spread across all the areas of the heart as reported in the cardiac pathology of the patients with COVID-19. So in fact, our patient possibly had a large number of the coronary microvascular obstruction into the LAD and the RCA territory, leading to the extensive infarction pattern. And what is the management of these patients? There is no specific management. Many of the patients, they do have the spontaneous recovery. We have to just do the supportive treatment. In fact, because he was having the multiple ventricular thrombi, he has to be given the therapeutic anticoagulation. The role of the steroids is very controversial, and if the patients are very sick and having respiratory distress, then you have to do the ventilatory support, or if they are in the cardiogenic shock, then the mechanical circulatory support is required for these patients. Now, coming in brief about the collateral damage of the COVID on the cardiovascular disease, this is the data from the UK, which shows the COVID-19 illness into the UK into the first wave last year into the month of the April and May, and then the second wave somewhere in December 2020 and January 2021. And what was observed, this is the pattern of the non-ST elevation myocardial infarction during the COVID illness. There was a sudden dip during the first wave, and the green dots here represent the presentation of the non-ST elevation myocardial infarction to the hospitals in 2019. So as compared to 2019, in 2020, there was a sudden dip on presentation of the non-ST elevation to the hospital during the first wave, which was not seen during the second wave. But when they saw for the ST elevation myocardial infarction, for that also there was a dip, though it was not as pronounced as for the non-ST elevation myocardial infarction. So various theories were put forward in the form that there is less pollution, COVID-19. I mean, the people started talking to the extent if the COVID-19 is protecting us from the myocardial infarction, but possibly we were not very well organized and the patients were staying back at home and not seeking the medical help, and we were better organized during the second wave, and the patients of the myocardial infarction, they presented to the hospitals as they presented in 2019 during the second wave over there. And there was a very interesting phenomena which was seen in the France. This is the blue line over here represents the first wave of the COVID, and here the peak of the second wave. This green line presents out of the hospital cardiac arrest from 2012 to 2019 in the Greater Paris area. And this red line over here, it represents out of the hospital cardiac arrest in 2020. So what they saw in 2020 during the first wave of the COVID, there was a tremendous increase in the out of the hospital cardiac arrest patients, though it was not seen like that into the second wave. So the patients, they were not seeking the help. They were not coming the hospital, and possibly these acute cardiovascular illness patients, they were having out of the hospital cardiac arrest during the first wave of the COVID-19. And this is also the registry study from the UK and the Brazil. The ischemic time, that means the symptom to the admission to the hospital, was considerably delayed, whether we consider ST elevation myocardial infarction, non-ST elevation myocardial infarction. Door to balloon time was significantly delayed, and all this translated into more cardiogenic shock, whether the patients were of the ST elevation or the non-ST elevation myocardial infarction, and the more mortality. And the same pattern was seen in the North American COVID-19 myocardial infarction registry over there. So a few words about hypercoagulopathy. The hypercoagulopathy, followed by the stroke, myocardial infarction, peripheral artery occlusion, and the pulmonary thromboembolism is seen. The small vessel platelet fibrin thrombi, microvascular thrombi, they are responsible for, they are seen in 80% of the cases. However, there are no suggestion about the treatment for these microvascular thrombi, though, because the etiology is in fact the endothelial involvement. And that is the reason in this interesting paper, which was published in the New England Journal of the Medicine in 2021, there was only very limited evidence of the use of the therapeutic use of enoxaparin in these patients, and they suggested only the prophylactic use of low molecular weight heparin during the acute COVID-19 illness. So what we need to do for these patients is a rigorous use of the plaque stabilizing agents like aspirin, statin, beta blockers, ACE inhibitors, wherever it is required. And we need to use the intensive antiplatelet therapy rather than the therapeutic anticoagulation. Even though when the patients are discharged, now the guidelines say that we use the anticoagulation only in selected patients who are known patients of the venous thromboembolic disease, or who are known to have predisposition to the venous thromboembolic disease, like the patients of malignancy. So in conclusion, if you see the patient of raised troponins and your patient is COVID-19 positive, admit the patient, assess the probability of having the coronary artery disease. If there is a high probability of the coronary artery disease, do the invasive coronary angiography. Intermediate probability of having coronary artery disease, do the CT scan or the CMR study for these patients. And if there is a low probability, then possibly these imaging studies are not required, and you have to look for the pericarditis, myocarditis, pulmonary thromboembolism, or the other reasons in these patients. Thank you very much for your attention.
Thank you very much, Dr. Kumar, for your presentation. And a very interesting case of the young man, 26 years old. I think we will have a lot of questions by the audience. Okay, so we can move now to Dr. Juwairiya lecture, and then we will have a question and answers. Doctora,
sure.
Your mic is yours. Thank you, doctor.
Thank you, Dr. Abdullah. I'm going to share my slides right now. Sure. Okay, so I'll be talking about cardiac imaging in COVID-19, and just as the numbers of cases are coming down and we're starting to lose the masks in certain areas, we're going to talk a little bit about long COVID as well, because this is what we're going to be dealing with after the waves of COVID subside, hopefully. Let's hope there's no other waves, but we never know. So talking about COVID and cardiovascular disease in every meeting, so whether it's internal medicine or cardiology, you're going to have a session. So in the last European Society of Cardiology, there was a whole track in the first day talking about COVID and cardiovascular disease. And what changed now from previously is we used to think that maybe the virus affects the heart itself, but now we understand it's the same as we see with every viral respiratory illness. It's the inflammation that causes all these problems. And because this virus is highly inflammable and there is a cytokine storm, this is what leads to the cardiovascular complications. So this was one of the presentations that we're talking about this. We're not saying that it's exactly the same as influenza, because look at this data from the CDC. So you see this yellow areas. These are the influenza cases over the years. So the death due to influenza, and these are the deaths due to COVID. So of course there is more death because this virus is more infectious and it causes more cytokine damage. But the reason for cardiac problems is the cytokine damage. It's not the actual penetration of the virus to the cardiac myocytes, as Dr. Agarwal mentioned. So now we understand this. It's most of the myocardial injury is indirect myocardial injury, happens because of the hypoxemia, hypotension, with tachyarrhythmia, critical care multi-organ dysfunction, pulmonary embolism, and the direct myocardial injury is very rare. It's less than 1% where you get myocarditis or acute MI. And if you look at patients with acute ARDS, so acute respiratory distress syndrome, whether they had COVID or non-COVID ARDS, you would actually find higher degree of troponin in patients who have ARDS non-COVID related if they had the similar amount of critical illness and organ dysfunction. So this all emphasizes that the problem is the inflammation, and the actual, critical illness and the organ dysfunction related to that is what causes myocardial injury. We're not saying it's not important, because it does increase major adverse cardiac events. So there's a 3 times increase in MACE after admission with COVID. These are data from UK. From US, we find the same 2 to 3 times increase in rate of cardiomyopathy, but this is because it's a widespread infection. If you have 1 million patients infected and you have 1% risk of cardiovascular complications, you're talking about 10,000 cases. And that's 10,000 cases that wouldn't exist if this virus was not there. So imaging in COVID has gained a lot of importance because it does find management changing diagnoses. So, and what's recommended usually is to do a point of care ultrasound, because point of care ultrasound is quick and it gives you the information with least exposure to the patient. And it can give you extra information that usually a cardiologist would not look at, because the cardiologist will look at the heart, will look at the LV, RV, pericardium, and the valves, which you can look by a point of care ultrasound, but you can also look at the vasculature, look at the GVP and the IVC, look at the leg veins for DVTs. And these are all related to associations that you see with COVID in terms of myocarditis, ACS, cardiomyopathy, PE, tamponade, and pre-existing cardiac diseases, and heart failure and DVT. So there is a specific consideration. I mean, if you look at your echo machines, if you're anywhere, if you use echo in your center, imagine doing an echo with the screen covered like this, and the light is reflected on it, with the probe covered like this, because you cannot sterilize the probe after every patient, because that will damage the probe, and the machine is worth almost $1 million dirham. So all of this precautions has to be taken. Some proposed having a screen between you and the patient instead of covering the machine. But then again, are you really sure that you are protected? and why is this sonographer not wearing a mask and not wearing a screen? So, it's a very problematic issue. So there are guidelines on when to do echo and what level of protection you need to have. And these guidelines came in for every single echo, not only echoes for COVID patients. And the first question is this echo indicated as this time? If it is not indicated at the time of a pandemic, you do not need to do non-indicated studies for this time. They can be done later. If it is indicated, do you suspect COVID or is it confirmed? If no, you would do standard precaution, and it's preferable to do droplet precautions for TEE. And if you're suspecting COVID and you're doing a transthoracic echo or a stress echo in the lab or the ward, you should use droplet precautions. But in an ICU or an operating room or an invasive or a patient that's invasively ventilated, you have to follow airborne precautions. And all TEE patients should follow airborne precautions. And it's better, you should look at special consideration to use POCUS. So TEE is possible in COVID patients. Of course, it's a nightmare to do because there is a lot. TEE is an arousal generating procedure. So it's like intubation. So anything in this room is currently exposed. So everything that's moved out of this room has to be cleaned afterwards. So there are preparations before, preparations during, preparation after. It's a complete nightmare actually to do it, but when it's indicated, it can be done. And the good news is there's other modes of imaging to do in a COVID patient. And almost every COVID patient will get a CT-PA. And you get a lot of information from the CT other than just how much the extent of COVID is and if there is a pulmonary embolism or not. Because they can comment on cardiomegaly, they can comment on chamber size. Frequently, you will see in the report saying what's the RV size compared to the LV. And they can comment about pericardial effusion. They're actually more sensitive than echo in detecting pericardial effusion. They can detect intracardiac thrombus, but you have to be a little bit careful about that, especially if the CT was not ECG gated, because it can happen that the contrast will swirl inside in the heart. So it will create the illusion of having a thrombus, but it's actually not there. So it will then depend on the level of comfort of the radiologist to call an intracardiac thrombus in such a situation. And usually we would confirm it later with an echo. Now, CMR is a high resolution. It can provide functional imaging and it has superior tissue characteristic, but it's expensive, it's time consuming, and it's really difficult to get an intubated patient into a CMR. And even some unintubated patients, they cannot tolerate it because it's so claustrophobic and they have to lie in the machine for at least an hour. So it's very, it can be very uncomfortable for the patients, especially if they feel short of breath. But it gives you ideas whether it's ischemic or non-ischemic injury, if it's stress cardiomyopathy, if it is myocarditis, if there is any evidence of pericarditis, and it quantifies chamber size, and it can actually measure strain. And nuclear imaging probably is not being used that much because of how expensive it is, but it does it can detect inflammation very well. So it's helpful in cases of myocarditis and in cases of endocarditis to see an FDG PET take. So sometimes when the image quality is not good and you cannot do a TEE, there is like prosthetic material involved, the TEE images are not that good. Nuclear image will help. I'm sure as I'm talking, everybody's thinking, well, when was the last time someone brought an echo machine inside a COVID patient's ward? And that applies to everywhere because these machines, it's very difficult to clean them. It's very difficult, and it's a huge exposure to the patient and to the sonographer and to every other patient that this machine is gonna be used at. So actually people looked at using a tablet-based limited echocardiography. So basically just using a handheld device and imaging the patient. And in this particular study, they looked at 91 consequent echo requests. Between all these 91 requests, 90 requests were done using a handheld device, whereas only one required them to use the machine. So basically 99% of the examination were done on a handheld device, and it provided sufficient information to manage the patient without doing a full echo. So you do not need to do a full echo. And the time that it required to acquire the images was 5 minutes, compared to 24 minutes by a regular a full echo. So that's something that can make you feel happy that you managed your patients very well, because a bedside echo with a handheld device is enough. What can you find? You can find a lot of range of abnormalities. I'm just going to skip that for the sake of time. Because I think we're running out of time. But the important thing to know is RV dysfunction is by far the most common finding that you would see on echo. So in one study it was reported up to 40%, in another study it was reported up to 26%, but it's the most common, and that reflects what COVID is. COVID is a respiratory disease. It's like when you have someone with severe pneumonia, when you have someone with ARDS, there is an increased vascular resistance in the lung that leads to increased afterload of the RV, that leads to RV dysfunction. So that's the most common finding that you would find. The next most common finding is to have a global or regional LV dysfunction. This is reported in the studies around the range of 20%, 20-24%. There is diastolic dysfunction reported, but the problem with diastolic dysfunction is it's very variable on how it's evaluated. So it's very difficult to extrapolate these findings, are they important or not? And then precardial effusions accounts for around 10 to 12% of the findings. There is also abnormalities in speckle tracking and longitudinal strain, up to 52% in a single study, but it's really difficult also to extrapolate these information because most patients have, in this particular study, patients were obese, Black, and had hypertension and diabetes, and these patients usually do at baseline have abnormal longitudinal strain. Okay, so which patients need an urgent echo? So this was looked at for all patients hospitalized for COVID between March 1st, 2020 to January 15, 2021. All patients had BNP and troponin measured, and the primary outcome was looking to find LV dysfunction with ejection fraction less than 35, RV dysfunction, wall motion abnormalities, moderate or greater precardial effusion, intracardiac thrombus, or pulmonary hypertension. And so basically, these are the major things that they looked at the study, because these are management changing findings. So if you have significant RV dysfunction, you might think of thrombolysis rather than just anticoagulation. You might need RV support, either medical or mechanical. If you had LV dysfunction, you might think of the need of revascularization, the need of LV support. If they have a thrombus, you need anticoagulation. And if you had large precardial effusion or tamponade, you need to do precardiosynthesis. So in this study, there were 434 hospitalized patients, 151 ICU patients. BNP and troponin were abnormal in 71% of patients, and urgent findings on echo were seen in 24% of cases. But the odds ratio for having an urgent finding on echo was increased if they have heart failure, if they had positive troponin, and if they had BNP. And there were no urgent finding in patients who do not have, who had normal troponin or BNP. So this is how you think about it. If you think this patient has a clinical suspicion of COVID cardiac complication, a high suspicion, you do an echo. If it's a low suspicion, you can do troponin and BNP. and that they're both normal, you can delay the echo. If one of them is abnormal, just do a POCUS or just delay the echo and do it later on. So troponin and BAP plays a major role. So what are the echo findings that are translating to high mortality? Mainly it's longitudinal strain and RV free wall strain. So strain does play a role, but as we said, it doesn't, like if you look at the odds ratio for age, it's 1.12, for lung disease is 7, for longitudinal strain is 1.18. So it's almost as much as age in terms of odds ratio for adverse events. Okay, so precardial disease and COVID, it's an important clinical manifestation, as I'm sure you all are familiar with, because of epicardial inflammation, because of microvascular dysfunction and systemic inflammation. And it's easily diagnosed by echo. And most pericarditis treatments like colchicine and corticosteroids are safe and efficacious for patients with COVID-19. And you can also find stress-induced cardiomyopathy in patients during the COVID pandemic. So there was an increased incidence noted of stress-induced cardiomyopathy during the pandemic compared to prior to the COVID times. And these were on patients that did not have COVID. So not only the patients who develop COVID are stressed, but also everybody else. So no patients with stress-induced cardiomyopathy was found to have COVID, suggesting that there is an indirect psychological and social and economic pandemic related to stress mechanisms. So role of CMR, Dr. Agarwal touched on this a little bit, but initially in the initial case reports, we were thinking that everybody with COVID will have myocarditis, and the reports were up to 7%. But currently, we do appreciate that it's around 1%. And given that the pretest probability of someone would have elevated troponin and COVID, the pretest probability of myocardial injury is more likely to be to coronary disease rather than myocarditis. It's always important to rule out coronary disease before doing a CMR. So the Society of Cardiovascular Magnetic Resonance endorses the use of CMR in COVID-19 infections when the results have immediate procedural implication, including but not limited to revascularization, valve intervention, necessary ablation, immune suppressions, or concerns of malignancy requiring cardiothoracic surgery. So if you have new LV dysfunction or clinical symptoms that raises concerns for myocarditis, an expert panel from ECC recommends CMR only after CAD has been ruled out by angiography or less invasive modalities like CT coronary angiography, because the pretest probability of ischemia is more likely than acute myocarditis. So this is the role for MRI in COVID. In acute infection, remember, it's not that common. So you want to make sure that if the clinical suspicion for myocarditis is high, make sure that you can order it, but make sure to rule out ACS first. And you need to do it during the acute infection only if it's going to change your management. For resolved infections, there are so many studies that looking at 60%, that giving numbers like 60% of patients are having some changes on MRI, but this doesn't translate clinically that much. And prevalence in larger cohorts are likely to be small, so we still need to look at more studies. So a few words about long COVID, because that's a very important topic that we're going to deal about right now. So we know acute COVID infection, after the infection, lots of patients continue to have ongoing symptoms, and we've heard about the post-COVID syndrome. What's long COVID? Long COVID is symptoms persisting beyond 4 weeks. And that's quite common, actually. There are more than 200 symptoms that can be related to long COVID. It has a fluctuating course. 1/3 of patients with COVID are unable to return to work or exercise. And risk factors for it are age, sex, severity of illness, socioeconomic factors, and prior medical history and prior history of mental illness. Of course, I'm a cardiologist, so lots of bubbles over here, but you can see palpitation is one of them, chest pain is one of them, dyspnea is one of them, orthostatic hypotension is somewhere around there. So cardiac complaints are common in long COVID, and around 80% of patients will have at least one complaint. The epidemiology is different according to which study and according to which country. Like if, for instance, here in hospitalized patient in China and UK and the French study, 76% had any symptoms. 56 to 63% had fatigue, around 26 to 48 had breathlessness, up to 27 had chest pain, and up to 20% had palpitations. But as you say, it's very variable accordingly, but it's common to have these symptoms. Postural orthostatic tachycardia syndrome is one of the probably the most common cardiac manifestation of long COVID. So it's defined as a sustained increase in the heart rate by 30 beats per minute within 10 minutes of standing or following head up tilt test. So, and this can be done easily in the clinic. You know, like you're doing postural vitals for a patient. The patient is sitting, you take their blood pressure and you take their heart rate, and then they stand up, and then at 1 minute, and then 3 minutes, and then 5 minutes, and then 10 minutes, you measure the blood pressure and the heart rate. If there is an increase on standing of 30 beats from the baseline, this is postural orthostatic tachycardia syndrome. And there are many proposed pathological mechanisms. It's a symptom of dysautonomia. It could be related to hyperadrenergic response, to alpha receptor sensitivity, to autoantibodies to adrenergic and cholinergic receptors. And these patients usually complain of palpitations, of feeling dizzy, of feeling sometimes short of breath. And it is known to be linked to post-viral illness. So again, not unique to COVID, but because we see a lot of COVID, then we see a lot of POTS after COVID. It might have an interaction with the ACE2 protein expressed on the neurons. And the management usually is related to education, exercise, salt and fluid retention. And if there is postural hypotension, midodrine can help improve the vascular tone. If the symptoms are mainly palpitations, then beta blockers and ivabradine can help. Okay, so what about in long COVID? What do you see in echo? Is the damage persistent, or does it stay, or does it recover? In follow-up studies, after 1 to 6 months of COVID infection, LV dysfunction was reported between 0 and 18%. So it's not that high. Diastolic impairment is reported higher, but again, challenging to interpret because you don't know who had diastolic dysfunction at baseline. Pericardial effusion is 0 to 14%. RV dysfunction is 0 to 18%, and chronic pulmonary hypertension is 10%. And cardiopulmonary exercise shows abnormal VO2 and reduced O2 pulse, which translate that this is a respiratory illness. So that's why O2 consumption is reduced. MRI studies have showed different kind of information. So basically, if you look at this study with 100 patients recovered from COVID, 78% had an abnormal MRI, but this was much, much higher than what's reported on other studies. If you look at this study comparing healthcare workers who had mild COVID, there was some MRI abnormalities, but they were not as impressive as the this JAMA article. So we still don't know what this means. Having 78% abnormal MRI results in these COVID patients, does it mean there is a subclinical inflammation that's not very important? It's not very clear to us until now. Pattern of myocardial injury in COVID positive patients are a variety of myocarditis and MI combination, or myocardial infarction. And there are some patients with ischemia, but without infarction. So we see quite a variety with MRI. How does that translate clinically is the challenge. And this is, again, a paper that's not yet published, but presented in the ESC last August, where you see that there is actually so at 2 to 3 months post-COVID, there are MRI changes that improve after 6 months and doesn't completely normalize. So this is the control, and this is the COVID patients. Same for RV ejection fraction. It does improve at 6 months, but it has no correlation to symptoms. So it did not show a difference in patient symptomology. So maybe we're detecting things that are all subclinical, only time will tell. So what do we do with the chronic pulmonary symptoms and the long COVID symptoms that we get? Most important thing is physical rehabilitation, early mobilization, exercise, compression stocking can help, lifestyle adjustment can help with adequate hydration and salt balance. And then the medical therapy for orthostasis is alpha blocker like midodrine, or for palpitation is beta blockers or navapriline. Just one word about heart failure and COVID. You heard about all the pathophysiologies of how an infection can cause worsening heart failure or push a patient into heart failure. This is something that we learned in medical school. Whenever you have someone with heart failure, you ask about a recent infection, and it's all in the heart failure guidelines that all heart failure patients should be vaccinated for influenza and for pneumococcal. And now I guess COVID is one of them as well. It should be in the guidelines. So how do you manage a heart failure patient post-COVID? If the patient had a pre-existing heart failure, you gradually reinstitute guideline-directed medical therapy, mindful of the effect of dysautonomia in these patients. Most of these patients have probably dropped their blood pressure, have developed some postural hypotension and are tachycardic. So maybe you push the beta blocker first, you leave the ARNI and the ACE inhibitors to be reinstituted later on as the patient progresses. But if you have a new diagnosis of heart failure during hospitalization, reassess the presence of actual structural heart disease. So repeat the echo, repeat the troponin, even repeat the cardiac MRI before starting or escalating guideline-directed therapy, because some of these are stress-induced cardiomyopathies, some of these are myocarditis, some of these are critical care cardiomyopathies that recover. So that does not mean a lifelong diagnosis of heart failure. And thank you very much.
Thank you very much, Dr. Juwairiya. That was very interesting topic. I would like first to apologize to the audience. We only have 5 minutes left, so I will direct one question to each speaker. I will start with you, Dr. Juwairiya. You mentioned the frequency of pericardial effusion is 0 to 14%. And, we do CT for almost all admitted patients. So when, as an internal medicine, when shall I call the cardiologist for echo, for example?
Okay, so if you do a CT, so CT is more sensitive for pericardial effusion than echo. So if you find mild pericardial effusion on CT, you do not need to call anybody, because mild pericardial effusion is probably just, small pericardial effusion in echo that has no hemodynamic significance. So what you need to call a cardiologist for is moderate and more pericardial effusion. If you have symptoms of pericarditis, so if you have ECG changes, chest pain, then you will need to call the cardiologist. And if the patient is hypotensive, because even a small pericardial effusion can have hemodynamic significance if it accumulated quickly. Usually with COVID, it doesn't accumulate quickly. And we haven't seen a lot of tamponades just for COVID, but it's a possibility. So if you have someone who's in shock, then yes, you need to look.
Okay, so my question to Dr. Sanjeev. Routinely, for every admitted patient, I've seen physician ordered troponin. Do you think this is like a good practice, or like a good practice to use troponin as screening for a patient with like mild myocarditis?
I think if the patients, the thing is, troponin, they can be, you can do the troponin, but what is important is the interpretation of the troponin related to the clinical presentation and the clinical scenario of that particular patient. When you do, troponins are essential, and the high sensitivity cardiac troponin, it can detect even the very small amount of the myocardial injury. But getting a positive troponin should not always raise a serious alarm and involvement of the cardiologist unless the troponin levels are dynamic, are gradually increasing, or are in infarction range, or you suspect that there are corroborative ECG changes, or there are some symptoms suggestive that this patient may be having or is having the high suspicion of the cardiac problem. In any serious illness like a moderately severe COVID sick patients, it's pertinent to do the troponin estimation.
Thank you very much, Doctor. Unfortunately, we are out of time. I would like to thank Dr. Sanjeev and Dr. Joeria for your nice topics and your time. By this, we will end our educational session. There is a 30 minutes talk by Dr. Niaz from Sanofi Industrial. Dr. Niaz, the mic is yours.
Thank you very much. So, can you see my slides?
Only your desktop showing, Doctor. I still can't see your.
This is the one. It's okay. Because, sorry, this. Okay. Is it okay now? Can you see the slides, please?
Now we can see your slide, Doctor.
Yeah, okay, thank you much. So Assalamu alaikum and good evening to everybody. And first of all, I would like to thank Sanofi for inviting me to give this talk on coagulopathy associated with the COVID-19. We all know the COVID and coagulopathy are two synonymous going together, and coagulopathy is the most important pathophysiological mechanism by which this COVID virus causes the disease. So in yes, so I'll be speaking about basically a brief discussion about the pathogenesis of the COVID coagulopathy, and then I'll discuss about the prevalence and incidence of the VT in COVID patients, and then I'll be briefly summarizing some of the new guidelines related to the COVID, related to the VT prophylaxis and the treatment in COVID patients. Now, just to recall our pathophysiology, so we all know that COVID, by this time, we know that COVID virus has got a spike proteins, and through this spike protein, it enters the ACE2 receptors, which are present on the surfaces of the most of the cells of the body, especially the pneumocystes 2, as well as the endothelial cells. Now, once they infect the endothelial cells, this COVID virus causes the initial endothelial injury. And if this initial endothelial injury is because of the increases in interferon 1 production. Now, if the person has got a vitamin D deficiency, then this injury becomes much more pronounced. So therefore, there's a much more pathophysiological mechanism involved if there's a vitamin D receptors, vitamin D deficiency is there. What does it cause? Actually, this initial endothelial injury, first of all, causes inflammation of the endothelial cells itself, what is called as endotheliitis, and it is characterized by the release of the various pro-inflammatory mediators like selectin molecules and IL-6 and IL-8, and at the same time, it also causes or starts a cascade of a coagulopathy by secreting or and activating the various pro-coagulant mediators like selectin, von Willebrand factors, and tissue factors, plasminogen PAI1 inhibitors. So what is consequence? These both pathophysiological mechanisms, they reinforce each other, leading to what we call as a severe damage to the cells which are involved, especially in the setting of pulmonary, causing severe endothelial dysfunction, induced vasculopathy, which causes pulmonary pathology and leads to a severe alveolar diffuse damage and leads further with the further consequences of ARDS and multi-organ things. Now, this coagulopathy actually corresponds with all this virus infect attacks are involves all the three basic mechanisms are through three of the Virchow's triad. First of all, as I mentioned, endothelial dysfunction by causing the release of the various activating factors. And at the same time, it also, we know in some of the COVID patients, as previously discussed by the speakers, once it involves the heart, it may cause various cardiac manifestations, which may limit the mobility of the patients. And similarly, if the patient is confined to an isolation room, so immobilization does factor. So this is a stasis factor is there, endothelial dysfunction is there. And what is the consequences that both of these things causes in hypercoagulable state, which is also increased by the release of the cytokine storm and various inflammatory markers and mediators like TNF, IL-6 and IL-2, granulocyte colony, stimulant factors, which they cause all induce in hypercoagulable states. So all three triparts, the agents which are known for a pathophysiology of Virchow's triads are being fulfilled here. So with the consequences that there's diffuse thrombosis in different parts of the body. Now, this was already, we know, I don't have to discuss now, but it was found very, very early in the COVID last year in February, March, that people having higher levels of D-dimers were found to have high mortality. And at the same time, some of the patients had, especially I think it was in China or Holland, they were able to do some post-mortem and they found that capillaries of the pulmonary capillaries, they have been blocked by the various microemboli and microthrombi, and that alerted the world community related to this microcoagulation or coagulopathy. And we all know that that these various stages of the pulmonary pathologies, as the severity of the lung damage increases, we have noticed that there's an increase in level of the D-dimers also. So there is a linear correlation of the D-dimer levels with the pulmonary pathology noted in these patients. At the same time, there has been some changes in the other parameters of the coagulation, like platelet count as well as the prothrombin time, which may be very much altered by the time where the patient has got a stage 3 or a severe ARDS due to the COVID infection. Now, the problem is that people were noted after finding that coagulopathy is the main problem, that this coagulopathy was found to be quite peculiar, and it was quite differentiating from other coagulopathy, which has been noticed in other viral diseases like influenza and syncytial virus. So what was the difference here? That it was, first of all, people have a higher fibrinogen levels along with the D-dimer, but the more importantly, these people, those patients, were found to have markedly hypercoagulable thromboelastometry profiles. What does it mean? It means that there is shorter clot formation. Whatever the thrombus is being formed in case of the COVID patients, there's a clot formation time is reduced. At the same time, there's a higher maximum clot firmness. So not only the clots, they form too rapidly, but these clots are quite firm, so therefore difficult to treat. So this is a peculiarity about the coagulopathy related to the COVID infection. And what are the other features? Of course, we have noticed clinically that there's a hypoxia out of proportion to the pulmonary complaints. Sometimes the hypoxia does not correlate with the clinical picture or the radiology findings, what was termed as a happy hypoxemia. At the same time, there's a microvascular thrombosis and hemorrhages, both in the interstitial tissues as well in the alveoli, and these there is just like a macrophage activation syndrome. There's an increased tissue factor, which I mentioned in the previous slides. There's increased PAI levels, and then there's a cytokine storms. These are the all basic pathophysiological mechanisms which differentiate this coagulopathy from the other cause of coagulopathy seen in DICs and other bacterial illnesses. So what does it cause? Now this specific feature, these specific features, along with bilateral pulmonary inflammation observed in COVID-19 patients, as I mentioned, is distinct from DIC. So it was being labeled and named as a pulmonary intravascular coagulopathy, PIC, as compared to the DIC. Now these raised D-dimers levels, they reflect pulmonary vascular bed thrombosis. If we all know this, and then raised cardiac enzymes, which were discussed in previous speakers, sometimes they may be reflecting an emergent pulmonary hypertension-induced ventricular stress. So there's these micropulmonary the emboli in the pulmonary parenchyma, they put a strain on the heart, which may cause mild cardiac damage with the elevation of the cardiac enzymes. So in the phase, and then at the same time, normal fibrinogen levels and platelet levels. So therefore, there's no DIC, which is, for example, we all know that in DIC, fibrinogen levels, they go down and platelet levels, they go down. But here, They are not there. So this is quite different from the DIC. So this is a PIC. So what are the clinical consequences of the PIC is that we all know that by this time now the 20% of the patients present with severe coagulation abnormalities, especially in severe and critically ill patients. And we all know that there's a concomitant VT, which sometimes may be the cause of an unexplained death. Although now we are well wise now before, but at the beginning of this pandemic, people were dying unexpectedly, and that was most probably due to the undiagnosed VT. And this hospital-associated VT remains undiagnosed still. And there has been, because there was a recent meta-analysis, I think about a few months back, they mentioned there's overall incidence of VT, hospital-associated VT is around 17%. But incidence is 4 times higher in those patients who are admitted in ICU as compared to those patients who have got mild to moderate disease and they are in medical wards. And it's similarly, although these statistics, they do vary according to the number of the patients and the various logistical and the facilities available. But those patients are those studies where the ultrasound was done or Doppler was done very routinely, 40% prevalence were noted of this DVT or VT. And not only this VT, but the problem here is that arterial as well as the venous, both thrombotic events are presenting either during at the presentation or during the course of the illness. And it's not only the macrovascular thrombi, there is a microvascular thrombi also. So this is an interesting phenomenon which is associated with this disease. So when we talk of the other sites are arterial thrombosis, ischemic stroke, myocardial infarction, and then especially those people who are having dialysis or extracorporeal circuits like ECMO, they used to have their catheters used to get blocked by this thrombus. Similarly, we have seen patients with mesenteric ischemia and limb ischemia as well, along with, of course, this microvascular thrombosis in the lungs and kidneys. In fact, in our department, we published a small studies. It was in last year about 28 patients who presented with ischemic stroke as a first manifestation, and 1/3 of these patients, they did not have any clinical signs of or a radiological signs of a pneumonia. And some of them, half of them, they developed later on once they came then admitted as and treated as ischemic stroke, they developed signs of pneumonia. So therefore, this was one of the things. So what to do this after knowing this pathology? So what we need to do is there are basically 4 steps which I want to highlight here. First of all, we need to have a risk assessment. Which of these COVID patients are at risk of developing VT, and what are the mechanism and methods for prophylaxis, and how to diagnose these cases, and then very briefly about the management. Now, what is risk stratification is very, very important for all the hospitalized patients, even for non-COVID patients. We all know that, and even if the patient is on the quarantine or in isolation, this risk assessment has to be done. Risk assessment, these models are being used in all over the world, and especially in medical patients. PEDO risk assessment model and improved model, these are being highly validated models which are being internationally used in various places. Yes. Okay. And then for the surgical patients, this risk assessment models is Caprini. So, but the problem is not only that we have to assess these patients for the risk of the VT, but at the same time, this assessment has to be done nearly on the daily basis because the patient's condition may change. Their clinical profile may change, their laboratory parameters may change, their disease severity may change. You might have prescribed some medications which might have affected these risk factors. So therefore, risk assessment has to be done nearly on the daily basis. And of course, it depends upon the location of the patients, where the patient is present. For example, patients who are admitted in ICU, they have got a very high risk of developing VT. Those patients who have got a high disease, severe disease, for example, other parameters we are also using like disease severity, community acquired pneumonia, we do disease severity. So these are things very, very important when we are doing the risk assessment for these patients. As I mentioned, these are the 2 risk models. We are doing it PETOA risk factor and improved risk assessment model. And these are for medical patients, but for surgical patients, we use the Caprini model. So how to prevent this PVs? First of all, in mild to moderate COVID patients, we have to go for the general measures. For example, we have to encourage their mobility. I know they are limited, sometimes isolated in a single room, but I advise these patients that even in the room inside, they have to keep themselves mobile, walking around in that small space. And of course, even when they are lying on the bed, they should do the exercise, active and passive exercise of all the limbs they should be well hydrated, and if they have got any evidence of a fluid loss, it has to be immediately replaced. And of course, if the patient has got a high or moderate risk of VT as assessed by this risk assessment model, then these patients should have a pharmacological prevention. And for the pharmacological prevention, low molecular weight heparin is recommended as a first-line treatment in the absence of contraindication. But here is very, very important to know that if these patients, they may have abnormal PTT and APTT also. So elevated PT or APTT is not in contraindication for a thromboprophylaxis. What about the severely and critically ill COVID patients? Of course, these patients, they are at high risk of bleeding, and especially some of them, they may have active bleeding. So in these patients, we prefer intermittent pneumatic compressions. But mind is, these patients, they are also at the risk of developing thrombosis also. So those patients who have got a low or moderate risk of bleeding and they've got no contraindication of the antithrombotic agents, pharmacological prevention is recommended as a first line for these critically and severely ill patients. Of course, if the patient has got renal impairment, then you have to adjust the dose of heparin. I will be discussing in next slides, few slides. Similarly, if the patient has got thrombocytopenia and you are thinking of heparin-induced thrombocytopenia, then you can use other non-heparin anticoagulants such as denaparoid, ergotropen, or bivalirudin, like these things. Although some of them, they may not be available, and then you can go for the rivaroxaban and fondaparinux also. Again, I will discuss in next slides. What about the topics? Now, some of these patients, they may have a risk of the VT even after they have been discharged, they have been treated for COVID infections. There's no data specific to the COVID exists, but at the same time, it is very reasonable to have individualized risk stratification for these patients. Now, if the patient may have a persistent risk, even at the time of the discharge, for example, cancer patients or those patients who have got elevated dimer level, then you can go for a prolonged outpatient-based VT prophylaxis from 4 to 6 weeks. It has been even considered. Same applies for the quarantine patient. If the patient is at home and if he has got a high risk of VT, then they have to be given this prophylaxis at home as well. Now, lower molecular weight heparin is preferred over DOACs because of fears of drug-to-drug interactions. Some of the antivirals, they do interact with the DOACs, and then of course they may have a lot of other comorbidities which may limit the use of DOACs. But however, lately there has been increasing use of DOACs even in the prophylaxis as well. Just few slides about the heparin. Why heparin is important here? Because it is not only anticoagulant effect, but it has got an anti-inflammatory effect as well. And because it downregulates IL-6 and it neutralizes some of the inflammatory markers, and it has been found in some of the studies that it might have even antiviral properties because it prevents the SARS-CoV virus surface receptor binding to these cells. Although these studies were very limited and not very substantiated, but this is the theoretical advantage of heparin as compared to other things. And then about this daily lower molecular weight heparins are recommended, daily over twice daily heparin. Now, normally, previously we were giving this unfractionated heparin also, but these things. So therefore, nowadays we are more preferring the lower molecular weight as compared to the unfractionated heparin. What about the heparin dose? Now, there have been a lot of debates about the heparin dose for last 1 year. Where at the beginning, when the people thought the D-dimer level is directly proportional to the mortality, so we started giving high doses of Clexane, even for a prophylactic prophylaxis to these patients, depending upon the level of the D-dimer. So some of the hospitals, they develop their own protocols depending upon the level of the D-dimers. For example, if it is less than 1, then standard prophylactic dose of Clexane or enoxaparin has to be given. If the D-dimer is from 1 to 3, then intermediate dose means 1.5 milligram per kg. And if the D-dimer is very high, sometimes these patients have been given a treatment dose of enoxaparin as prophylaxis, not as a treatment. But so some of the hospitals, they have adopted weight-adjusted molecular weight heparin prophylaxis depending upon the body weight of the patient. So if the patient has got a less than 40 or 35, then you give the average dose of enoxaparin. And if the patient is above 40 grams, 40 BMIs, then perhaps you have to increase the dose of these things. But so every hospital and the institution has got their own protocols. I'll be just discussing in one of the recommended guidelines as well. Nearly the same thing here, which I'll just skip these things. Just to mention here that many experts now think that patients who are are in high flow oxygenation or who have got high severity of the disease, moderate to severe, then these are patients whom you can think of giving them an intermediate dose of thrombophylexis rather than any standard doses. The diagnosis, Dr. Javaya mentioned about the difficulty of doing echo, so because it's very, very important that clinicians should have a low threshold because the hallmark of the COVID pathology is a coagulopathy. So therefore, one has to be very high alert. If the patient is unexplained tachycardia, hypotension, and you think his hypoxemia is disproportionate to the chest X-ray finding or clinical findings, or if the patient has got unexplained right ventricular dysfunction or right heart failure, then perhaps these are the patients where you can strongly think of having a massive pulmonary embolism, which is causing these consequences. However, it's very important to know that elevated D-dimer alone does not warrant routine investigation for acute VT, because D-dimer, as I mentioned, it is very common high in many patients. So therefore, if high D-dimer does not mean that your patient may have a VT. Similarly, elevated troponin was discussed. There are so many reasons for having elevated troponin. It may be due to non-specific myocardial injury, maybe due to kidney issues, myocarditis, small pulmonary embolism, type 1, type 2 myocardial infarction. So one has to think in that. So elevated troponin may not only be due to pulmonary embolism. Similarly, elevated Belgian natriuretic peptide, which is sometimes is a marker for a heart failure or pulmonary fluid overload, is also non-specific, and it should not be really considered as a suggestion or a indicator for a patient that patient might have a pulmonary embolism. So it is all your gut feeling and these experience, not the laboratory things, which will suggest the patient has got any thrombic event. The imaging is difficult. The reason is very much very common logical, because the problem is you need to protect the other patients and healthcare workers also. Your patients cannot come out of the isolation, because your patient may be requiring high oxygen. He may be on a non-invasive ventilation. The patient might be intubated, so therefore it meets the facilities. So you cannot transfer this patient to an echo room or any imaging room there. Similarly, there's always a danger of contaminating your equipment, and then your radiology department might be too busy to, or there may be some logistical issues as well. So therefore, it's very, very difficult that you don't have to really go for imaging if you are really clinically suspecting the patient has got either DVT or a pulmonary embolism. What about the medical therapy? Now, medical therapy is there a therapeutic anticoagulation, the mainstay of the VT treatment. We all know that you need to consider the comorbidities, kidney, liver, and all the things. It's very important. And parenteral anticoagulation is preferred as compared to the oral things. And because of shortage of time, I will skip the things. Now people have been using DOACs, especially, there are limitations of that. There are some advantages of DOACs, because that you can give oral also, and you don't have to monitor. But at the same time, one has to think that it's because the antidote of these DOACs may not be available in your hospital, so it may be difficult to counteract if the patient starts bleeding. And mind that these patients are already at high risk of bleeding. So there has been plethora of guidelines. I'm not going to discuss all these guidelines. Very briefly, I will summarize the ASH NIH guidelines, and then lastly about our own UAE guidelines. What do they suggest? Now, first of all, it is mentioned for monitoring in non-hospitalized patients, there's no need to do the coagulation markers like D-dimer, platelet. Okay, and again, these laboratory markers should not be used to predict the risk of VT. However, if the patient is hospitalized, then we are always doing these hematologic and coagulation markers, but they should not be determining and guiding the management. Okay, this is very important guideline which has been mentioned here. What about the non-hospitalized patients? Again, when you are giving them anticoagulation, antipeptide therapy should not be used for the prevention of VT or arterial thrombosis. As a routine, we are talking of a patient who are at home, unless the patient has got some cardiac indication for taking this antiplatelet or anticoagulant. On the other end, if the patient is hospitalized, then of course they all should have a prophylactic anticoagulation. And again, this anticoagulation is for prevention of the VT, but it's not prevention of arterial thrombosis. Again, if your patient has got ischemic, non-ischemic heart disease or atrial fibrillation, then you are justified to give this anticoagulation. But this prophylaxis is only for VT, not for arterial prophylaxis. Although it will benefit that thing, but indication is only for the VT. Again, the presence and of the underlying conditions will determine which medicine you want to use. And okay, so this is very important. What about the diagnosis here? Currently data is insufficient to recommend should we do any routine DVT screening in patients. For example, your patient has no signs and symptoms of DVT, but you find D-dimer, there's no need to do routine DVT, routine imaging for these patients. But however, for hospitalized patients, as I mentioned before, if they develop clinical features of pulmonary, cardiac, or neurological dysfunction, then you can think of a thromboembolic disease should be evaluated. But again, now what about the discharged patients? Now, sometimes hospitalized patients should not be routinely discharged from the hospital on VT prophylaxis unless, as I mentioned in my earlier slides, if they've got a higher risk of developing VT at home also, then you can have a prolonged or extended prophylaxis. What about the anti-cell agents? This is the same thing which I'll just skip this because just one here thing is very important, because as I mentioned, antiviral drugs like favipiravir and remdesivir, they may have some interaction with these drugs. So we always prefer these heparin substitutes. Pregnancy also, sorry, here this is interesting this year. In pregnancy also, there's not much changes. So pregnancy will not really change any these things. And here it's very important that these heparin as well as warfarin, they do not accumulate in the breast milk. So therefore, they do not induce any anticoagulant effect. So you need to continue the same therapy like non-pregnant patients. What about the chronic treatment? Again, as I mentioned here, if the patient is on warfarin, then you see, it will be difficult for them to come to hospitals for a follow-up. So during these times, you can switch the patients to dogs. But on the other hand, if the patient is taking warfarin because of the valvular atrial fibrillation, then they have to be continued on the warfarin. On the other hand, if the patient is hospitalized, and if they are taking already anticoagulations, then you have an antiplatelet agents due to some other medical conditions, then you have to continue all these anticoagulations unless patient develops contraindication like bleeding. What about the treatment? When the treatment is not, when diagnostic imaging is not possible and you have a gut feeling that your patient has got developed VT, then better to treat the patients. So these patients should be treated as with therapeutic doses of anticoagulant therapy. On the other hand, if the patient, for example, who require extracorporeal membrane oxygenation or ECMO, or they are on renal replacement therapy, or they've got catheter thrombosis, then you have to give them antithrombotic therapy as per the standard guidelines and recommendations. So this was about this one. Now, what about ASH guidelines? Very briefly, one slide about these things. The guidelines very clear. They mention, ASH mentions that suggests that using prophylactic intensity or intermediate intensity or therapeutic intensity anticoagulation for patients with critical illness, those who are in ICU. So they still recommend that you just go for a standard prophylactic dose. You don't have to increase the dose of enoxaparin for a higher doses. On the other hand, same is recommendation for patients who are in ward also. You have to give a low intensity or a normal standard doses of prophylaxis rather than high dose of prophylaxis. Although there have been some of the new trials have been coming up, and one of the earlier results of these trials were published, I think, last month in New England Journal of the Medicines. I'll just skip these things. So here is nearly more or less repetition of these same these things. Now this is UAE guidelines. This is late guide. We have got many versions of this. This was in June 2021, and again, UAE we recommend that therapeutic doses should not be offered because of the risk of bleeding. We're talking about the VT prophylaxis here. So therapeutic doses of should not be offered. And then thromboprophylaxis, the low molecular weight heparin should be considered in all patients who require hospital admission for COVID infection in the absence of any contraindication. And then we suggest a dose according to the weight. For example, enoxaparin standard dose is 40 milligram, but if the BMI is high, then you can increase the dose twice daily, this 40 milligram. And pregnancy, we recommend same dose. If the patient has got renal impairment, if the GFR is more than 30, then no adjustment is required. If it's less than 30, then you have to reduce the dose of the enoxaparin accordingly. So these are our own guidelines, and we have got separate guidelines. This is an extensive document, is available online as well. But so this is, and what about the prophylaxis, extended prophylaxis at home? What we recommend is from UAE, if your patient has got a high risk of VT even after discharge, what is the high risk? You go by the RAM, that means risk assessment model improves. If the score is 4, or if the score is 2 and he's got a dimer levels high, even at the discharge, then these people can have extended prophylaxis at home. And what is extended prophylaxis at home? We talk about 4 to 6 weeks up to 39 days. And nowadays, we have been recommending the lower dose of DOACs, especially the rivaroxaban, those patients who are discharged home. Some of the patients, they still continue and prefer enoxaparin at home, but alternative is smaller dose of rivaroxaban for extended prophylaxis. These are the ongoing trials, which these are a large number of the trials are being there. They are comparing the therapeutic doses versus prophylactic dose. 11 trials are comparing outpatients, especially for the outpatients, and they are comparing enoxaparin, aspirin, DOACs. Similarly, 25 trials related to the heparin-based regime. So there's a large number of trials are coming up. And just very briefly, 1 or 2 slides about some of the trials which have been published now. These are preliminary reports, only published recently in New England Journal of Medicine. The full results are not yet published. But what they find out that in this study, they compared of those patients who are not really admitted at home. So they compared the use of aspirin versus small dose of apixaban versus apixaban high doses versus placebo. We are talking of a prevention here. And then what was the report here? This study was discontinued because in these patients, those with a low risk of VT, there was no thrombotic events. So therefore, this study was discontinued. But what about the other patients who were admitted in medical wards? And so they compared the full doses of prophylaxis, full therapeutic doses versus preventive doses. So these are the 4 trials. And what they found here, that 40 to 70% reduction in the risk of VT in those who were given a full dose or a full dose of prophylaxis. So, but at the same time, there was 2-fold increase in the risk of major bleeding and major bleeding. So, for example, and the reduction in the risk of mortality also was same like in other trials. But so therefore, in those patients, there was some risk reduction. But what about the intermediate doses and preventive doses? The results are not yet there. But these results was really going against the guidelines which are doing it now. So what about these critical ill patients which are admitted in ICU? So these trials, they compared again in these patients. What they found is there's a reduction in the risk of PE in one of the trial, not in other studies. And there was no impact on all-cause mortality. And there was some increase in the risk of major bleeding and no impact on the number of organ support-free days. And what about the intermediate and preventive anticoagulation difference? There was no difference in VT mortality using. So therefore, these results are still not very clear cut, and we'll still wait for the full results before they become a guidelines. And what about the post-discharge? Now this study, action study, they compared this was from the Brazil. They compared about 615 patients, those who had elevated D-dimer levels at discharge, and they gave rivaroxaban 20 milligram, or a full dose of enoxaparin during admission. And these patients, they were discharged on rivaroxaban 10 lower doses for 30 days. So what they found, primary outcome was that mortality and the duration of the hospitalization. And what they found, there was no difference in the primary outcome or VT in these patients who were given extended prophylaxis. But they had a higher or 3.6-fold increase in the risk of major bleeding, and there was no difference in the mortality. Nearly same findings with Michel study, Brazil also, they were doing assessment according to the improved risk assessment model. Okay, what they found that there was a 67% reduction in the primary outcome, means these patients, they develop VT. But again, there was no increase in the risk of this organ saving days. And then symptomatic VT was 5% in those who were in placebo as compared to 0.6%. So their new studies, again, they go back to the same thing. Maybe in patients who are at high risk of developing VT may be given a higher doses of prophylaxis. So what are my take-home messages here? So we all know that COVID-19 disease predisposes patients to arterial and venous thrombosis. Both micro and macro thrombotic events can occur. High-risk patients can be identified by these coagulation markers, but they should not guide you as far as management is concerned. And all hospitalized patients should be placed on VT prophylaxis, preferably with low molecular weight heparin, unless there's a contraindication. Strong clinical suspicions of VT with suggestive parameters may be enough to diagnose and treat without confirmatory imaging. It's very important to understand. And then therapeutic anticoagulation should be strongly considered in patients at high risk for coagulopathy, those on renal replacement therapy or an ECMO, and are those who have signs of microthrombi-induced organ dysfunctions, or they have well-documented macrothromboembolism. Now, aspirin may be considered and should be considered in those patients who have elevated troponin and cardiac dysfunction. Okay, and lastly, now the patients have a right to expect that their hospital stay is safe and that the risk of adverse events such as venous thromboembolism is minimized. It is time to roll out risk assessment for all hospitalized patients globally to guide the use of an appropriate thromboprophylaxis. Now, such an approach will of course save lives, reduce mortality, and reduce morbidity, and also costs for the healthcare systems. I think that's all here. Thank you very much.
Thank you very much, Dr. Niaz. I think it's end for the day. It's too late now, 9:30.
Yeah. Okay. Thank you very much. Thank you, everybody.
Thank you.